Thanks so much. It's a pleasure to be here, and it's a pleasure to be part of Aspetar, and so it's an honor to share this talk with you. And we're going to talk about a little bit about leg pain in athletes. And for me, it actually began many years ago with a rhythmic gymnast who came to my office with leg pain, and it was relatively atypical. She was young and trying to figure out the problem, and then actually developing some techniques for her that we've then continued over the years is really kind of the motivation of how I got started in all of this. Okay, so what I want to walk you through here, just to get your minds thinking a little bit, just think about a few different case examples. A 21-year-old collegiate distance runner presents with gradual onset of increased leg pain with impact. She has been able to run through the pain, but her times are getting worse. What kind of things are you thinking about? Is there anything else that you want to know about this young lady? 15-year-old elite level gymnast. She's ramping up her training for an international event. She's a key member of the team. It's about 6 weeks before the international event. She gets leg pain, particularly related to landings and tumbling. Is she going to be able to play? What's the next steps for her? How about a 16-year-old high school soccer player? 2 years history of calf pain treated by numerous different doctors. Workup included imaging, bone scan, MRI, EMGs, all kinds of stuff. Treatments included non-steroidals, massage, physical therapy, bracing. Nothing seems to work. Very frustrated. What's next? What's going on? 20-year-old volleyball player. Now there's a little bit more active. Volleyball player sees you in the training room, was practicing today, has had a history of shin splints, she tells you, but now the pain is getting worse and just won't go away. What's the thoughts? What's going on with this person? 33-year-old female runner, mother of two. She has a knee scope. She's discharged home with early mobilization. She gets a little mild leg pain and fatigue at post-op day number 3. What's going on? What should we be concerned about? So my ultimate goals that I want to walk you through is really kind of trying to find ways to optimize outcomes by making the proper diagnosis for leg pain. That's really going to be a key for us to sit there and think about the broad differential diagnosis, think about the anatomy that has a potential of causing leg pain, and then narrow the diagnosis. That's going to be really key because to accurately treat it, you need to know the specific diagnosis. Become aware that sometimes these things get a little confusing, and unfortunately, one diagnosis doesn't mean another one's not involved. So there's oftentimes overlapping diagnosis, and then ultimately, when things don't fit the classic presentation, then you start having to think about unusual things and create a broader differential diagnosis. So, leg pain in athletes, common or not? Exercise-related leg pain is very common. About 15% of runners will have leg pain, and so that and oftentimes they're going to come talking to you about leg pain, or they're going to say, "I have shin splints." Now, one thing I'm going to tell you, hopefully, if you're going to learn 4 pearls as we go through this, and you're going to leave here and go, "Hey, I didn't think about that." Maybe 3 or 4 different things. One of them I hope you leave with is, as a clinician, as a doctor, don't call it shin splints. So shin splints is something they'll come in and say it's just kind of a weird word for a leg pain, but we should be able to make a more specific diagnosis, an anatomic diagnosis, because this is really too broad for us. So throw away shin splints, think about the specific diagnosis. So top 4 common things. When I talk to my residents and somebody comes in with leg pain, in athletes, these are the 4 top things I want to think about. I want to think about exertional compartment syndrome. I want to think about stress fractures. I want to think about medial tibial stress syndrome. In all honesty, that's what most people call, I told you to throw it away, shin splints, or chronic muscle strain. So those are the things that we want to be thinking about. And then potentially in that mix, popliteal artery entrapment syndrome. Rarer, but it's something I also consider. So we want to beware of atypical population. So one of the things that I was mentioning to you is you think about an athletic population, we're going to think about those top 4 or 5 diagnoses. Now you sit back and go, well, I've got this 50-year-old person that has leg pain. I have children that have leg pain. When it starts to get in an atypical population, then you have to start thinking about a broader differential diagnosis, and you have to think about more atypical things. So easy classic things in athletes, think about those top 4 or 5. start getting different populations, think about different other diagnoses. So how do I narrow this? I have somebody come in and they just have leg pain. So you have to start narrowing it down ultimately by anatomy. So we think about the different anatomic structures and what could potentially go wrong to lead to potential leg pain. So at least I'll start thinking about it anatomically to help narrow what's going on. Bone. Bone is clearly a broad continuum. As athletes run and train, they can get a stress injury of the bone. There's no stress fracture. There's no absolute fracture yet. It's simply an overuse process of the bone. And then as they progress, it could progress to a stress fracture or, in really terrible times, a completely catastrophic injury. The periosteum is also very highly, a lot of nerve fibers in the periosteum. And so either a direct contusion on the periosteum or, more commonly, some type of an enthesopathy where actually muscle and tendons that were originated on the periosteum chronically pull, maybe because of alignment issues, maybe because of bad foot positions, maybe because of bad shoe wear, but they ultimately load. And this is really an area people have considered for a long time was what led to medial tibial stress syndrome, was something with the periosteum. Now that has been debated because they've been thinking maybe it's bone. So somewhere with medial tibial stress syndrome, it's probably somewhere between these two different pathologies. Clearly then beyond the bone, muscles and compartments. You have to know that there are four, some people say five, four key compartments in the leg, and we're going to have to think about those, and we're going to have to ultimately know which muscles are in the compartments and ultimately know which nerves are in each of the compartments, because as we get our symptoms peripherally, it may clue us into where something's going on. So you can have muscle herniations, muscle tears, and exertional compartment syndrome because of involvement of the muscles. Nerve issues, three classic nerves, the tibial nerve, peroneal nerve, sural nerve, all can have entrapment of some sort. Now, neurologically, you have to think about a broader differential diagnosis. So when people start saying, I have numbness, tingling, weakness, you have to, if it's not classic, that it's associated with exertion, then we're going to be looking at things like chronic regional pain syndrome, systemic problems like Charcot-Marie tooth disease, proximal radiculopathy, a herniated disc that pinches on the nerve that goes distally, peripheral nerve entrapments, just so simply the nerve is involved, nothing else is going on. So all of those things we have to think about neurologically. What's else in our leg? Vascular issues. So venous issues. This is where you think about potential as issues of blood clots. Older populations, think about vascular claudication. Venous stasis changes. Arterial problems, clearly with a major catastrophic injury, we can have a major artery problem, but more commonly, it may be some type of an entrapment issue like popliteal artery entrapment syndrome that can lead to an arterial flow issue that leads to pain. So anatomically, we want to think of all of those differential things, and then again, continuing our broad thought of what can go on. Nutritional things, more commonly probably in our athletic population, cramping related to dehydration or some types of electrolyte variations. Metabolic things and other systemic things can occur, clearly significantly more rare. Again, those probably are going to be those patients who come in and they didn't respond to your simple first-line treatment for your more common diagnoses. And then, unfortunately, you have to always not forget the zebras. At least with our when we talk to the orthopedic residents, now when somebody has atypical pain, it won't go away. We can't forget about osteosarcoma and some tumors, trauma or abuse, infections. But generally, again, those are going to be something that'll give you other clues to their pathologies. And clearly, one of the reasons somebody who comes in with a leg pain, I will always get baseline x-rays because it helps me screen for some of these atypical problems. So then probably now for the physiotherapists and my primary care sports colleagues, some of the other key issues that we want to think about with leg pain is not just that broad differential diagnosis of the anatomy, but really some of these associated factors that could potentially also contribute to leg problems. So these have the potential of being treatable that have led to the leg complaints. Overall alignment, gait mechanics, sport-specific demands, what's their training, how much have they increased their intensity of training, shoe wear, does it actually help control flat feet, pes planus, high arch feet, does it have extra cushioning? Those things can have direct correlations to the cause of leg pain. We talked about age in certain populations playing a role also. Now, we mentioned when you started, we've created this broad differential diagnosis, and we're going to walk through the specific common diagnoses, probably with a special emphasis on exertional compartment syndrome, which is something that I've actually written a fair amount about. But we're sort of going to walk through those common diagnoses. This is kind of giving you this foundational baseline of what to broadly think about when an athlete presents with leg pain. So one of the concerns I always have is even for my common diagnoses is that oftentimes we can have an overlapping diagnosis. Exertional compartment syndrome can occur with medial tibial periostitis or medial tibial stress syndrome and can occur with stress fractures. And in fact, I've had a number of people who have had exertional compartment syndrome types of pain, and then you realize that they had a stress injury of the bone. You treat their stress injury, and the localized swelling, either around the medial tibial stress or because of the stress fracture, the swelling in that area goes down, and then their pressures go down, and it can go away. And so ultimately, if I would have just did an exertional compartment release on that patient, it was unnecessary. Or sometimes if you treat the stress fracture and it doesn't go away, it's because they had an exertional compartment syndrome simultaneously. So you got to think about those potential overlapping diagnoses. And I think one of the most common reasons that you'll see in a second, we talk about outcomes of exertional compartment procedures, why people are have poor outcomes, it's because they missed these associated diagnoses. So you have to think about this overlap all the time. So, clinical clues and pearls to think about when an athlete's presenting to you with leg pain. So, pain with first impact. This is the jumpers. This is the runner who says it's not later on when I run, it's the first time I'm landing and hitting, that's when I'm starting to have pain. That's the classic presentation of a stress fracture. Yes, we can have periostitis. Yes, we can have medial tibial stress syndrome, but the most common thing with that presentation, at least in my mind, is a stress injury of the bone. Now, on clinical examination, if they have a focal area of pain, you can cover it with your thumb or your finger. It's not broad. If you're on the bone, one spot, that's a stress injury of the bone. And in fact, one of the games I'll play is when I get my x-ray, I don't actually go to the x-ray first. I'll actually go to the patient, find my one spot, measure it so I know exactly where it's at, and then look at the x-ray, magnifying it, looking at it carefully to see if I see a small radiolucent line. Oftentimes the radiologist will miss these very subtle findings, but if you have that direct correlation with your physical examination, it's probably real. And if you did a bone scan, it'll probably prove you to be true. The broader tension over the bone, so now it's not one focal spot, it's actually a broader area, particularly over the posterior medial border. That's medial tibial stress syndrome, probably. If they have focal muscle pain, this can be a strain, can be DVTs. If they have pain with resisted motion, that's going to be classically a muscle strain. If they have pain with vibration, this is kind of an interesting one for my therapy colleagues who sit back and go, hey, I like to treat a little leg pain with a little ultrasound. Low-level ultrasound actually creates enough vibration that actually irritates a stress fracture. One of the things I'll carry in my game bag is the tuning fork. Whack the tuning fork, follow it along the shin. If they hurt with that one spot, then that's probably a stress fracture. If they have pain with exertion, so now it's not pain at rest, they're sitting relaxing, no big deal, they go to train, that's when they start having pain. For me, that's exertional compartment syndrome until proven otherwise. That's my leading diagnosis. And then ultimately I have to think potentially if it's actually in the calf, not anterior lateral, then those I'm going to be thinking about popliteal artery entrapment syndrome. So those two diagnoses are commonly exertionally related. Electric radicular pain, certainly some type of a nerve impingement, whether it's proximal, peripheral, herniated disc. If it has pain at night, wakes them up at night, I'm thinking about tumors. If they have major motor weakness, again, some type of a neurologic issue proximally. If they have paresthesias, so numbness and tingling at rest, is commonly some type of a nerve entrapment. If they have paresthesias with exertion, the dorsal aspect of their foot goes to sleep when they're running, I'm back to exertional compartment syndrome. And in fact, this one, the paresthesias with exertion, oftentimes you can start paying attention to them and say, well, where are you numb? If they're numb on the dorsal aspect of their foot, then that's probably an anterior lateral compartment involvement. If they're actually on their plantar aspect of their foot, now I'm worried about a deep compartment problem. Other issues, focal swelling, we think about muscle herniations. If they have diffuse swelling, worry about DVTs. If they have cramping or spasm. Now this is not really a focal area of pain. It's not pain with exertion. It's not pain with impact. It's really more this cramping pain. That's the ones I'm going to start looking at, electrolytes and dehydration. Now we've walked through these clinical pearls, and I think that this is important to think about them because for me, what I'll do in terms of my workup is I'm thinking about this broad differential diagnosis of leg pain in athletes, but my next step generally target, like I told you, I get x-rays pretty much on everybody, but the next targeting examination, MRI, bone scan, lab studies, whatever it is, it's really going to target what my number one diagnosis is. So I'm going to track down the first diagnosis and then rule out those other potential overlapping diagnoses. Now, compartment syndrome, we're going to talk about that a little bit. It's probably of all the different leg things, my favorite of the things to talk about. And first, I think we have to be aware of the two different issues of compartment syndrome. One is an acute compartment syndrome, one is an exertional compartment syndrome. Acute compartment syndrome is the one that we probably all, well, hopefully we all know about both of these, but acute compartment syndrome is the one you have to know about. It's the orthopedic emergency. It's basically the one usually associated with trauma, a fracture. There's so much pressure in the compartment that it does not go away with rest. It's getting worse, it's getting worse, it's cutting off their circulation. Actually, the muscles are dying inside their leg. If they don't have a fascial release right now or very early, they're going to have permanent damage of their muscle and they could potentially lose their leg. So that's an orthopedic emergency. Exertional compartment syndrome, actually same anatomy is involved, except that it waxes and wanes. So no pain at rest. With exertion, usually 5, 10, 15 minutes into a run, they start developing pain. They relax, it goes away. So the fact that it goes up and down is probably a little bit comforting to us, but we also have to be very aware that sometimes athletes say, "Oh, the doc gave me the diagnosis of exertional compartment syndrome. It's not a compartment syndrome," he said, "so I'm just going to run through it." Bad idea. Number of patients have been that actually go through this and say, "Well, I had pain. I actually ran through it, kept going." They can convert themselves from an exertional to an acute compartment syndrome. Now they have an orthopedic emergency and they need to be released right away. So you have to know the difference between those. So for my orthopedic colleagues, what's the risk of closed tibial fracture for compartment syndrome? So now I had we're worried about compartment syndrome. How often does it happen? Well, interestingly, 10% have changes, or 20% have impending compartment syndrome if you have a significant tibial fracture. So now if you have an athlete that comes in with a significant injury and you think you're just thinking about casting it or splitting it, you need to pay attention to that as a potential issue. Talk briefly about compartment anatomy. This is going to be important for us as we walk through this, and that is that 4 key compartments. You see this potential fifth compartment may be a reason why deep compartment problems tend to have a higher recurrence rate. They tend not to all have great success rates. But the most common compartments involved with exertional compartment syndrome are the anterior and lateral. 80% of the time it's anterior and lateral that are involved. So for me, if the athletes come in and it's not anterior lateral, they're already atypical, I'm starting to look at potential other things in my differential diagnosis. Think about which muscle groups are actually involved in each of these compartments, because those are the ones that are going to get hurt, or be painful with resistance. So if they hurt with eversion of their foot, their perineal nerves are involved, that means their lateral compartment is probably involved. If they actually hurt with active plantar flexion, then it's probably a deep compartment or superficial compartment. And then when we look, think about the nerves that are involved, that's going to help us figure out when they start saying, "Hey, I have a little numbness on my first web space on the dorsal aspect of my toe. When I run, I run a little bit, it starts getting painful, I start dragging my foot a little bit, I hear a slapping sound when I run, and I get this numbness between my first web space." Well, that tells me that their anterior compartment is probably involved. It just defined it for me. Now they have numbness over the dorsal aspect of their foot, probably lateral compartment. So you think about these things and it'll help clue you into what's going on. So how do you make the diagnosis of an exertional compartment syndrome? Well, we've had our clinical presentation of pain with exertion. Ultimately, that's my number one diagnosis. I got my x-ray. Next thing I'm going to do is check their pressures. I'm going to check their pressures before and after exertion, and then it's really kind of debatable in the literature, is this a valuable thing for us to do? I will tell you that I still do pre and post-exertional compartment pressures. That's what I do for everybody. The Pedowitz criteria basically says normal somewhere between 0 to 10 millimeters of mercury, resting somewhere less than 15, Stife says less than 30, and then post-exertion, bottom line for me, Pedowitz says greater than 30. I say it jumps up more than 10 from where it was at rest. So if it goes up more than 10 millimeters of mercury, then my exertional change increased my compartment pressures, and it's probably a key issue. And then there's a potential delayed test. So some people like to say, now you wait 5 minutes, retest, and it's still over 20 millimeters of mercury. It's probably positive. Now, these have actually been debated fairly significantly recently. Some people question the reproducibility, the validity of these potential measurements. And there's different issues that relate to that. Some of that here you can see doing a deep compartment pressure with a Stryker monitor. Some people have suggested that this continuous tip is a problem, and therefore they like to have the transducer actually at the tip. They think that that's more reproducible. I had a debate with some Matt Hislop and some other people in the British Journal of Sports Medicine of whether you test just one compartment. So you think you have an anterior lateral compartment involved, so you just check that pressure. Actually, I would argue that you check the pressures of all 4 compartments on every athlete, because you're there just doing the test. You want to know everything that's going to be involved. Personally, if I do surgery, I want to know if I have to do all 4 compartments or if I can get away with just one, and I don't want that athlete to ever come back. So I want to know what's involved, which compartments are involved, so I can make a smart surgical decision. So some of the other debates, some people have suggested a dynamic test, that is to say with a continuous monitor. Now instead of what you saw with a Stryker monitor, you put that needle in, you check the pressures, you have them go run, immediately come back, check the pressures again. You can actually put a continuous catheter in and see what goes on. Different numbers with this. Some people say greater than 50 with a continuous monitor. Some people say greater than 100. The challenge that I've seen with a continuous monitor, though, is we actually did some studies with this, and I think that there's some important things that we can learn from continuous monitoring. But what happens with the continuous monitor, we had a continuous monitor in place, and my residents would sit back and go, okay, hey, let's see what's going on. And they got the stopwatch out, and every 5 seconds they go, okay, what's the number? And they go, well, it's 20. No, now it's 100. No, it's 100. It's 15. No, it's 75. It seemed it was just jumping around. Until you actually, when they were running on the treadmill, you sit back and go, oh, wait, you're doing this wrong. Don't count seconds. Sit back and go, foot flat, foot flat, foot flat, foot flat. And they go, oh, 35, 35, 35. And so it actually depends on which phase of gait that they're in that the pressures will spike. So if you know what the spike relationship is, then it can make a big difference in terms of helping to make that diagnosis. One way to do that is actually to assess the amplitude of the pulse, so actually how much it jumps up and down during those testing. So not just absolute numbers, but actually the amplitude of the spikes. That has actually been shown by Nielsen and others to have the potential of being more sensitive and more specific than just simple pressure measurements. So I've not switched to this yet. I'll still do pre and post exertion. I don't do the delayed measurement, and I do all 4 compartments on everybody. Some people have suggested doing exertional MRIs. I think this is a very expensive way to do it, but clearly you can actually see the difference with exertion of the edema that happened in that anterior compartment. So if you happen to see that because you did an MRI scan, then I think it can help prove your diagnosis. I think it's a fairly expensive test to actually try to make the diagnosis. Another group of people have suggested using near-infrared spectroscopy, same thing that you do when you put the little pulse ox machine on your finger, and they suggested about 75 to 85% sensitivity. Huge advantage to this is that I don't have to poke needles into them. I don't have to put a catheter into them. The problem is the sensitivity, even in their study, was 75 to 85%, not quite as accurate as the other intercompartmental pressure measurements. And probably the biggest issue is that the machine itself costs about $18,000, and then they'll charge you for these little pads significantly. And so I think it's an expensive device. And by the way, this Hutchinson Technologies is not me. Actually, there's an interesting story. The Hutchinson Technologies, I said I wanted to do more research, particularly with this device. So I called them up because they're in Minnesota, a state in the United States. And I go, hey guys, give me one of these devices. I do these tests all the time. I'd like to compare between the two. And they go, I don't think we really want to give you one. And I go, hey, it's Hutchinson. Come on. It's like Uncle Bob or something. You could give me one. They still wouldn't give me one. So maybe that's why I don't really support the technique. I don't know. A variety of treatment options for exertional compartment syndrome. Classically, you sit back and go, okay, I'm going to give them some non-steroidal medicines. I'm going to do massage. I'm going to do rest. I'm going to do stretching and other physical therapy. I'm going to use modalities. I'm even going to change my shoes or surfaces. The outcomes of these things, pretty poor in terms of actually treating the problem. And it's because the problem is actually the tight fascia that's led to the exertional compartment syndrome. More recently, there's been a couple of different studies looking at potential toe running, so switching from a heel toe to a toe running gait, or potentially botulinum, giving them Botox injections into their compartments to reduce their pressures. So what do we know about those? Now, the toe running, I think, has significant potential. And in fact, I do know that one of the articles from Aspetar has actually wrote and talked about this. My criticism for the toe running is that I don't think we know enough about it yet. So trying it is okay as long as they're not running through pain. But if you look at these different studies, unfortunately, they're all still level 4 studies. They're all just, hey, we put a few patients together to see what they did. And in fact, the total numbers, first study, they had 70% success, but it was only 10 patients. Second study, only 2 patients. Last study, back to about 10 patients. And so it's interesting, and I think it's something to think about, but we have to also think about if we're changing somebody to a toe runner, how does that affect their performance? If we change them to a toe runner, how does that affect their stresses? Are they going to get stress fractures in their forefoot because now they're running on their toes? Just things we have to think about in terms of making some of those decisions. Botox, is it successful in terms of relieving the compartment pressures? Actually, yes. There's a couple of studies now that have actually showed that the pressures can actually fall 63 to 68%. Pain relieved in 15 out of 16 patients. There's other studies that actually support that. So actually the concept of Botox is not unreasonable. But I'm not sure why in my athletes, if I'm doing leg pain in athletes, why I have 69% that have decreased strength. So if I use Botox, I'm actually weakening their muscle, and I think that there's a potential problem in our athletes of doing that. If you have somebody else, maybe it's something to consider. In terms of surgical techniques, variety of things. For a compartment syndrome, classically, you'd actually make a big open incision. For exertional compartment syndrome, we can do it through smaller incisions. Not sure if we can make that one work. What we actually developed for that young lady I was telling you about in the first thing, classically, instead of making 2 large incisions, we actually said, she's a performance athlete. We wanted to see if we can do smaller incisions. And so what we are ultimately able to do is we did a single incision. I've actually switched now to 2 small incisions. And then through the 2 small incisions, we actually identify the intermuscular septum. We create a fascial plane above the fascia, below the skin, and then use retractors to identify the fascia. And then using an arthroscope, really more an endoscope, we're actually able to visualize our cut proximal to distal to release both of the fascia. The other study that we actually did ultimately was to show that if you actually do 80% rather than 100% of the complete fascial release, you'll have complete fascial release or pressure release with an 80%, not complete release, which means you can avoid making your cuts all the way to the end. Somebody's modified that, and here you can see what they did. 2 small incisions, proximal and distal. What they did is they pass a suture from top to bottom, and that what they do with that suture is they use that suture actually as a retraction device rather than what I use as long retractors, which is kind of a cute technique to try to see how it works. How about outcomes of exertional compartment releases? So we have somebody, we've told you that I've not been happy about Botox, not been happy about changing running on their toes. I think that's a choice. But if you do surgery, what's the outcome? We tell our patients about 80 to 90% of the time you're going to do better. Generally, I tell them quietly if it's a young lady. If you're a young lady, it probably is a little bit less. Why? Actually, I think the less in women is probably misdiagnoses. I think it's something else that we missed, probably. But Lyle McKaylee showed us in the past that the outcomes for women, instead of, if we're saying 90% for men, maybe it's 85% for women. Here you can see some recent studies, though, that question those outcomes. What do we know? In terms of active duty military people, exertional compartment releases, not so effective. 41% back to active duty, 17% in the second study required a medical discharge, 44% had recurrence. Now, when I went back to look at these studies, I'm not sure if they were so careful about making the diagnoses and looking for associated diagnoses. So I think that one of the issues for these is not to miss those associated diagnoses. They may have some secondary gain in saying, hey, I get out of the military because it's not getting better. But the other thing is if you look at the Winky study from British Journal of Sports Medicine, the other thing that we know is that if you have to do the deep posterior, anterior and laterals do really well, about 80 to 90% success rates. The deep posterior, they don't do as well. They have more complications. They have more pain afterwards. They get more stiffness. They have more potential hematomas. So we have to be careful. The success of those posterior releases are less. And in fact, years ago, I actually made the change even before 2014. And I will tell you, when I started doing these, I sit there and go, you have a pressure positive test. Then I released all 4 compartments surgically. Same kind of concept. I said I didn't want to come back. I stopped doing that because I had more complications posterior medially with cellulitis and things like that. So then I started saying, no, I'm just going to release just the compartment or the side that's involved. I try to avoid the deep compartments if I can, if the pressures aren't positive. So what are our outcomes? At UIC, we've now done over 300 endoscopic releases. Our outcomes have actually been excellent, primarily with the anterior and lateral releases, again being very specific about what the diagnosis is by pressure positive measurements, 90% significant resolution and return to play. So most all of them have got back to play. I can't say everybody's perfect. We've had 4 injuries to the superficial branch of the superficial perineal nerve, and I'll say branches, because if you ever do this surgery, what you have to realize, it's not one nerve. It comes down, and everybody thinks it comes down, goes to the back of your foot. Unfortunately, different people have branches. Some of them have 2 or 3 branches, and I can identify one, I protect it, and I think I'm safe, and then I do my release, and I miss the other branch, so they get a spot of numbness. So I think that happens sometimes. I think you have to make sure your patients are aware of that. I've had 18 postoperative cellulitis, which means almost 6%. I think that's terrible. But I think the problem is I have this big dead space underneath the wound, and so I really watch these really careful. How do you try to minimize this? Careful soft tissue protection during the surgery, avoid over-retraction, and then I give everybody perioperative antibiotics for 3 days, not just a single day, not just at the time of the surgery. We've had some people with stiffness, particularly with the posteriors. Most of those resolve with therapy. Nobody with a permanent stiffness. A couple of technical things that I've learned from doing this. I have switched instead of the 1 incision to 2 incisions, and the reason I did that is because you can make the small distal incision. You can see the superficial perineal nerve a little bit easier, particularly when I'm teaching residents. Within the 2 centimeters of the wound, I use it as a flashlight. Deeper to that, then I'll use the endoscope to actually visualize things. Again, like I said, we published this in the American Journal of Sports Medicine. All you need to do is 70 to 80% of the length of the fascia, not 100%, and you get the same effective release. We alternate polar care, a cold device, to decrease the swelling, which I think decreases the risk of hematomas and cellulitis postoperatively. So that's kind of the most common thing that, or at least the biggest thing that I look at through the exertional compartment stuff. I'm going to flash you through some of the other potential diagnoses around the leg. Muscle herniations. This is going to be a muscle bulge, a muscle through the fascia. This is actually commonly associated with exertional compartment syndrome. What do we know about those? And in fact, people have talked about doing a repair of that fascial herniation. Better thing to do is just actually complete the release, just like you would do for an exertional compartment syndrome. The successes can be just as good. Popliteal artery entrapment syndrome. This is actually now this exertional pain in the posterior calf. This is one of the reasons I think that there's a higher failure rate of people that do posterior releases for compartment syndrome, is they miss this diagnosis. So you need to think about pain with exertion, and then we have to figure out what's the flow. So for anybody with posterior calf pain, I always do additional studies. So I'll look for popliteal artery entrapment syndrome rather than labeling them with a posterior compartment. Here's some of the different anatomic variations. It's pretty amazing what goes on. You can have the artery straight down the middle like it's supposed to be, but then you have some weird variations. You can have it actually where the artery's wrapped around the medial gastroc, goes through the medial gastroc. So all of these different things, you can just have bands of tissues that pinch on it. So all of these things, these variations actually can lead to problems of this flow and complaints posteriorly. Clinically, one thing that you can do is listen for a bruit. And so everybody laughs at me, and I don't know if Scott's going to laugh at me. I actually have the most expensive stethoscope in the world, which is this Littman Cardiology that I can turn up the volume. I think it's maybe my age as a doctor, but as an orthopedic surgeon, I'll do this, and I can try to listen for bruits in this area to see if I can find a pathology. The other thing that I like to do in the office is, this is one of the times that I'll borrow my primary care guy's ultrasound machine, and what I'll do is I'll do an ultrasound dynamically. And here you can see the ultrasound. Patients when she plantar flexes, you can see actually the lumen disappear. So you can do this with plantar flexion or dorsiflexion. You can actually see the flow quite nicely, and then I can clinically make the diagnosis of an exertional compartment syndrome. So, or excuse me, a popliteal artery entrapment syndrome. So classically then, once I have that, I will then do some type of a diagnostic test, usually an MRA to confirm the diagnosis, to try to visualize exactly the flow and where the entrapment is, see if there's some variation in the arterial anatomy. If there is an anatomic variation, the success of the release is over 90%. If there's no anatomic variation, if they have a functional type of popliteal artery entrapment syndrome, their success rates go down. Again, some people have suggested using Botox here. I think they've reported some success with it. Stress fractures, originally described by Bryhopt, about 1 to 25% of exercise related to leg pain is related to stress fractures. It's most commonly in the tibia. Can also be in the fibula and in the feet. Coexisting issues. So she had irregular menses. She had a poor energy balance. She had a history of previous stress fractures. All tells me that actually she had the female athlete triad. So one of the challenges here is I had to not just pay attention to the fact that she had a stress fracture. She was going to get more of them if I didn't get her treated for her global health of the female athlete triad. 15-year-old elite level gymnast wrapping up for training for trials, cancellation for competition for an international event. What do you think she had? So stress injury of the bone, stress fracture possibly again. But the question is unfortunately she's 6 weeks before the event. Is she going to play? You think she's going to compete if you're starting to get a stress injury of the bone 6 weeks before your international event? Yes? No? Think she's going to fracture through? We had that terrible one we just had with the soccer player. Well, this is actually Dominique Moceanu. She was arrested to avoid her landings. She had bone stimulation, 2 different types, so every magical thing they could do to try to get her back. They did brace her with an air stirrup. So she actually continued to train, but no dismounts or landings. She actually competed at the Olympic Games, and this was her. So this is Moceanu, and watch on this vault. Okay, here now she's on her second vault. Why can't she do this? She can't land. Why? Because she had the stress fracture in her bone. She hasn't been practicing her dismounts and landing. All because she had a stress fracture of the bone. She hadn't been practicing. And it forced Carrie Strug, who actually, interestingly enough, had a grade 1 ankle sprain before that first vault. She actually converted herself to a grade 2 to 3 ankle sprain after that first vault, and then did the second vault to ultimately win the gold medal for the team. Basically, if you watch this one, again, kind of a leg issue because she actually did that one-legged. How about our 16-year-old high school soccer player, 2-year history of calf pain, treated by numerous doctors, had a variety of workups, everything was negative. What do you think he had going on? Compartment syndrome? Actually, you had to think about a broader differential diagnosis. He had a positive MRA, he had a positive Brewy, he actually had a popliteal artery entrapment syndrome. And so that he had a posterior calf type of pain. How about our volleyball player who had a history of shin splints, and then she developed pain that wouldn't go away in the anterior aspect of her leg? What'd she have? This gal actually she converted herself to an acute compartment syndrome. So she had anterolateral pain. She converted herself to acute compartment syndrome. It wasn't going away. Her pressures were elevated. She ultimately required an acute surgical release because she had converted herself from an exertional to an acute compartment syndrome. How about our 33-year-old female runner, mother of 2, routine arthroscopy for meniscus, discharged home, post-op day 3, had a little fatigue, little pain. Okay, everybody's for DVT? Good. This is a terrible story, by the way, because we know that she was on oral contraceptives. She was evaluated in the office. This was not me. This was her lungs were clear, normal vital signs. She had mild mid-calf pain, mild pain with calf squeeze, but no cords, no distal swelling. Says, okay, here you can go home. She actually collapsed at a Denny's or a little local food store, and ultimately died of a PE. So. The question then, I guess, is what are the indications for routine prophylaxis after or for basic arthroscopy? And I think it depends. If somebody's on oral contraceptives and they're overweight, they probably should be more formally prophylaxed. Europeans actually commonly will routinely prophylax basic arthroscopies with Coumadin or Lovenox or some other types of medicine. The United States, we don't do it as frequently. Personally, I recommend everybody gets both chemoprophylaxis and mechanical prophylaxis, which for me is aspirin and compression stockings as well as intermittent TEDs during surgery. I think that's a minimum response, and for every female that's on oral contraceptives, I stop them before the surgery. So, last things to what have we learned? Avoid non-diagnostic terminology. So throw away the word shin splints, be very specific about your diagnosis about the leg pain. How do you do that? Think anatomically. That's going to actually walk you through the specific diagnoses. Common things are common, but when the presentation is atypical, that's when you have to think about the zebras, the weirder things, broaden your differential diagnosis. Look for the overlapping diagnoses, because if you don't, then your treatments aren't always going to work. You have to treat all of the problems to actually have the best outcome. Consider these contributing factors. Look for alignment, look for gait mechanics, look for shoe wear, look for the surface changes or training changes, all of which can contribute to their leg pain. Target the most likely diagnosis. So for me, everybody gets x-rays, they get a great history, they get a good physical exam, and then after that, I will sit there and go, oh, you got exertional compartment syndrome, I'll do the compartment test. Yeah, I think they have popliteal artery entrapment syndrome, I'll do an MRA, or I'll do my ultrasound in the office, those types of things. Don't be afraid of compartment testing. One of the things I see not uncommonly is either my primary care colleagues or emergency rooms sit back and go, I think you have a compartment syndrome, but I don't think so, or I don't know, we're not going to test you. We're going to wait for the vascular surgeon or the orthopedic surgeon. It's a very easy test to put that little Stryker monitor in. So don't be afraid of it, pretty easy to do. I may be frozen. Oh well, we can. It's the computer's frozen. Last couple things is that ultimately, as you walk through, for me, doing these leg pains, sometime long time ago, with that first little gymnast that I took care of, I started doing some research studies with leg pain, and I've done a variety of presentations, and now I'm here talking to you. And so the lesson learned from that is be careful about finding a niche, because it might follow you for the next 25 years. So that's what I have.